exam, which is more let's say, which is more relying itself, of course, on textbook information or textbook knowledge. Let's go on. We will have a 63-year-old man continues to experience chest pain, has a temperature of 47 to 8 for 2 days after an acute MI. His EKG shows widespread ST elevation with upward concavity. This is really important, guys. And upward concavity means like this, okay? It's like this one. It's more indicated for pericarditis. What is the single most likely explanation for the abnormal involvement? So, first of all, Dressler syndrome is mostly seen after 2 weeks. Left ventricular aneurysm, this is of course, an aneurysm should be more, let's say, profound, and it is seen, of course, in the first 2 to 4 days, but there are other hit points. I will explain it to you in the following slide. Atrial thrombus, not seen very well because atrial thrombus will not lead, of course, to fever. Also, left ventricular cardiac tamponade will show you, of course, the Berg sign, hypotension, elevated Kussmaul's inspiration. So during the inspiration, the veins gonna collapse, and of course, elevated jugular vein pressure, and of course, acute pericarditis is the mostly seen thing, or let's say directly you can choose the answer acute pericarditis. You know very well that the pericarditis is seen with chest pain in the first 48 hours. You can see it with chest pain, cough, dyspnea, flu-like symptoms, pericardial rub. It's like if you are walking on snow and you are hearing the rushing of your shoe. If the shoes are pressing this snow on the ground, then you will hear the rushing of the snow. Tachypnea and tachycardia, of course, are also seen. Let's go on further. This is a question which will only give you a hit point. A patient who had a transient ischemic attack, which he recovered from. He has a history of stroke, and exam shows a heart rate and sinus rhythm. He is already on aspirin 75 mg and antihypertensive drug. What other action should be taken? For patients with transient ischemic attack, there will be other slides or other questions about that. They're asking this very often in the PLAB examination, Notice very well that clopidogrel and clopidogrel is in the prophylaxis the most important drug for transient ischemic stroke. And secondly, of course, statins are also very, very important. If the patient has hypercholesterolemia, or if the patient has internal carotid artery in the Doppler, for example, atherosclerotic or narrowing of the internal carotid artery of more than 50%. Some guidelines are saying more than 50, some are 60, but let's say more than 50%. So this question, of course, directly add clopidogrel and statin. You should see it directly and take this as your as an answer. A 72-year-old man is found to be not breathing in the cardiology unit with the following rhythm. What is the most likely diagnosis? So there is actually, let's say here we will have the question is a little bit confusing. I have taken this question directly because there was actually, this is a question from the exam, there was actually no any following rhythm. There was no actual picture about that. But I will, what are you going to do with this, let's say with this question? What you can do about this question is, it is not breathing, and even in intensive care unit, but there is no picture. You can directly say that this is a ventricular fibrillation. Also a very easy question, which you should directly can solve as a doctor. So if you're seeing, for example, this is actually the picture of it. Later on I brought it, but the question was without any picture. But this is a picture of a ventricular fibrillation. If you're seeing something like that, directly, of course, the patient is not breathing, is in the care unit, and this is a picture about that, or there is no picture in the question, and he's not breathing, which can be the answer, of course. Ventricular fibrillation, very easy also. So let's go on. So this is an important question. They will ask you this topic very often, and you should know it very well. A 65-year-old male patient presents with dyspnea and palpitations. Exam, pulse 170, blood pressure is normal. A cardiac massage has been done as first instance. So this is, of course, something giving you a clue about what it is. It's a supraventricular tachycardia, because in supraventricular tachycardia, you will not see any default pictures mean are these questions common? Yok arkadaşlar, çok öyle çok common değil de öyle bir örnek, yani öyle bir örnek vardı şey içerisinde. Böyle biliyorsunuz soru havuzu var kocaman. Biz onlardan soruları şey yapmıştık. Böyle bir şey vardı, yani karşınıza gelebilir mi diye. Ben nasıl yaklaşacağınızı öğretiyorum, yani worst case scenario şeklinde. Çok öyle bir default picture falan gelmez ama öyle bir öykü olduğunu söylediler, ama bu çok eskiden olan bir şeydi. Korkmanıza gerek yok yani. Genel olarak picture falan gelir, merak etmeyin de. Yani picture olmasa dahi o hastada ne düşüneceksiniz? Yani koroner yoğun bakımda hasta nefes almıyor, abicim bu ventriküler fibrilasyondur. Direktman tak yani, onu düşüneceksiniz. Onun için şey yapmaya çalışıyorum. Ve bazen eksantik bir şey yapmaya çalışıyorum ki sıkılmayın diye. Ondan dolayı. So, what is the next step of management? Supraventricular tachycardia. Let's look. Adenosine. Okay, let's go. This is a picture of supraventricular tachycardia. Regular rhythm. The intervals, RR intervals, are normal to each other. The P waves are in the T waves. You see, you will not see the P waves. And of course, the QRS are very narrow. So this is a picture of supraventricular tachycardia. The RR intervals are normal. The P waves are not seen or are masked under the T waves. And of course, the QRS are not widespread. So this is a very nice algorithm for tachycardias. I'm going to explain it a little bit because this is very important. They're going to ask you this in the question in the PLAB. So the patient comes to you. Tachycardia with pulse. This is very important. If you have a tachycardia without pulse, nabızsız arkadaşlar VT biliyorsunuz. This is another indication. We're going to talk it later. So first of all, assess support, airway, breathing, and circulation. Give oxygen and monitor the EKG. So first of all, is the patient stable? Of course. If the patient is stable, then of course you can directly take the EKG and look at the QRS. So if the patient is unstable, if the patient is stable, you should directly take the EKG and look at the QRS, if it's narrow or not. We're going to come to this. Let's go. If the patient is unstable, first of all, an immediate cardioversion should be done, guys. This is very important. Signs of shock, hypotension. This some guys are understanding from an unstable patient, the patient who is not its mental, the Glasgow Coma scale is 0, not like that. It can be have a chest pain, have hypotension, or other signs of shocks. So what you're going to do, of course, is synchronize cardioversion for those patients. Then we will have a QRS. The QRS, if it's narrow or not, 0.12 seconds or 120 milliseconds. If you have a narrow QRS, then you're going to look if it's regular or not. So the patient here has a narrow QRS and it's regular. So this is a supraventricular tachycardia. So what we're going to do in supraventricular tachycardia is that you're going to first of all make a vagal maneuver. If it's not helping, you're going to can give adenosine. Adenosine can be given 3 times to those patients. And notice very well that adenosine is something which is contraindicated in patients with asthma. And secondly, of course, in patients who are using theophylline, it can increase the amount of adenosine. And there are other drugs which can decrease the amount of adenosine, but you don't have to know it. Note theophylline and asthma, okay? Notice this in your mind. So you're gonna do this adenosine if it's does the rhythm convert? No, it does not convert. When it doesn't convert, you should of course think about atrial flutter, ectopic atrial tachycardia. Those are other things. I'm gonna talk this later on. But if, for example, the rhythm converts, mostly it's the supraventricular tachycardia. So it means that a patient who is directly responding to adenosine, which is blocking, of course, the AV node, those patients are usually patients with supraventricular tachycardia. Of course, you can give these patients to treat, of course, recurrence, long-acting for long-term therapy, diltiazem or verapropyl, mostly we're giving diltiazem or verapamil. Beta blockers are not that much used in supraventricular tachycardia in the clinical practice. If the rhythm doesn't convert, it can be other diseases, not very important. So when we have, of course, irregular narrow complex tachycardia, it can be atrial fibrillation, atrial flutter, or multifocal atrial tachycardia. Only know this if there is an irregular narrow complex, atrial fibrillation, or atrial flutter, or multifocal atrial tachycardia can be seen. Paroxysmal atrial fibrillation is, for example, something which can lead to hypertension or shock. Then, of course, we will have a white one. If it's white one, we're going to see again if it's irregular or not. Notice this atrial fibrillation with aberrancy is not important for you. This is something which you should not know, guys. Only in this topic, know this. Torsade de points, okay? Torsade de points is something which you should know. And patients, especially alcoholic patients, for example, can come with you with hypomagnesemia. Hypomagnesemia is something seen very common in patients with alcoholism or patients with anorexia nervosa, and very low magnesium levels can lead to torsade de points. Hypocalcemia can also lead to torsade de points, for example. So this, you should notice what is torsade de points. There is another picture I'm going to show you what torsade de point is. And if there is ventricular tachycardia, of course, or uncertain rhythm, of course, we're going to look here. If there's a pulse, we can do it with amiodarone or for a synchronous cardioversion. This is something which you don't have to know. Okay, so you're going to look. Patient is stable, QRS. If it's low, if it's more right QRS, it's ventricular tachycardia with pulse, amiodarone, okay, or synchronous cardioversion. Then, of course, a neural QRS. You're going to look if it's irregular or regular. If it's regular, supraventricular tachycardia. First, vagal maneuver. Second, adenosine for long-term therapy, diltiazem or verapamil. If it's irregular, you're going to think about atrial fibrillation, atrial flutter, or multifocal atrial tachycardia. And of course, if the patient, for example, is a tachycardia and is unstable, of course, immediate synchronized cardioversion should be done. Okay? So this is something which you should know. And of course, the contributing factors should also be done. Hypocalcemia, hypoxia, hyperkalemia, hypoglycemia, hypothermia, toxins, tamponates, of course, thrombosis, trauma, all those things, of course, should also be evaluated in those patients. Okay?